Next, please. Now coming to the clinical signs. How do you assess which are the poor clinicals? Absence of pupillary light reflexes, absence of motor response on pain, myoclonic jerks are present, and they can be predicted early also. Most of the patients we have seen who have severe cerebral injury, they start having myoclonic jerks within a few hours. They are much worse than SE. Next, please. Now, coming to the prognosticators, now which are not good prognosticators. Some depends on age, sex, cause of arrest, type of arrhythmias, time, total arrest time, and the duration of CPR. Next. Now, this is an AAN summary of evidence-based guideline for clinicians, which tells us the prediction of outcome in comatose survivors after CPR. So, level 1 evidence was found that if the prognosis was poor in comatose patients who had absent pupillary or corneal reflex, or absent motor response, or extensive motor response was there even after 3 days of cardiac arrest. Patients with myoclonic status epilepticus or myoclonic seizures within the first day of the circulatory arrest have generally a poorer prognosis. Now, circumstances around the CPR, the prognosis cannot be based on that. If there is elevated body temperature, you cannot predict the prognosis. If there is a weak evidence that it will affect prognosis in any way. Next, please. So neurological examination and seizures, they are the poor prognosticator markers. Now, EEG monitoring, overall prognostication ability is not very strong. Various studies have looked into it, but there is a lack of standardized classification system. Concerning features are burst suppression, non-reactive alpha or theta patterns, or if there are generalized periodic complexes. These are the poor features. Now, there are some other tests also like SSEPs, which is Somatosensory Evoked Potentials. These tests, they test the integrity of the neuronal pathway. That is from the peripheral nerve, spinal cord, brainstem, and the spinal cord. That is from the motor to all the way to the cerebral cortex. Next. So there is a good evidence that assessment of poor prognosis can be guided by the presence of bilateral absent cortical SSEP, that is also called N20 response within 1 to 3 days. If it is absent, then it means there is poor prognosis. Next, please. Biomarkers. So whenever the brain is damaged or dead, it releases biomarkers. Now, the 3 specific well-studied biomarkers are neuron-specific enolase, which is also called NSE, S100, and CKBB, which is creatinine kinase BB isoenzyme. So NSE levels of more than 33 microgram per liter at days 1 to 3 post CPR, they accurately predict the poor outcome. So if the level is high, it means the outcome is going to be poor. There is insufficient evidence for serum S100 and CKMB and intracranial pressure and brain oxygenation, although they are not very routinely used, but NSE is quite routinely used in hospitals and is a good marker for poor outcome. Imaging. So you have to understand what is written. Although not strong and enough to prognosticate reliable, a bad scan is a bad scan, which means that if you are looking at a bad scan, that it shows the brain is quite bad, then it means it is bad. But the problem lies that if it is a good scan and your patient is not good, then it may not be a good scan. It can again be a bad scan. Next, please. So coma decision algorithm, exclude the major co-founders. If there is no brainstem reflexes at any time, that is pupillary reflex, corneal reflex, oculocephalic reflex, cough reflex, then yes, you do a brain death testing. Or if on day one you have myoclonic jerks, it will indicate poor outcome. Or day 1 to 3, you have NSE levels, which are more than 33 microgram per liter. It indicates poor response, poor outcome. Day 3, absent pupillary or corneal reflex. Motor response is either absent or is extensor, poor response. Day 1 to 3, SSEP or absent N20 responses, poor outcome. So as you can see, major role is that of biomarkers and your clinical examination. There is very less role of EEG and imaging. This we have already discussed. This is the same as that of the last slide. So the next question is, although his EKG shows normal sinus rhythm with non-specific changes, should he go to a cath lab? Because he had something, because he had suffered a cardiac arrest. So if we should take him to a cath lab, what are the recommendations for cath post cardiac arrest? If he arrested again, would you thrombolize him? And what is the etiology of the vast majority of cardiac arrests? Next. Next. So what is the etiology of cardiac arrest? Next. It is in 65 to 70% of the patients, it's ischemic heart disease, leading on to coronary artery disease, which may present as MI or angina, coronary artery embolization, disease of the coronary artery in the form of arteritis, dissection, or coronary artery spasm. 15 to 35% have non-cardiac diseases in the form of pulmonary embolism, ICH, drowning, drug-induced Pickwickian syndrome, central airway obstruction. 10% may have non-ischemic heart disease, like in the form of hypertrophic cardiomyopathy, dilated cardiomyopathy, myocarditis, rupture, dissection, or could be no structural heart disease, only the electrical, like in the form of arrhythmias, which can present as complete heart block, familial sudden cardiac death, long QT syndrome.